Hello guys, good morning. Welcome you all on Unacademy, India's largest learning platform. Myself, Dr. Nidhi, I'm your physiology educator at Unacademy. You can follow us on Telegram also. This is my page on Unacademy, that is unacademy.com/KGMC. The description box also consists of this link, so you can go there and follow me out there so that you will get notification of any upcoming classes of mine. This is the code Dr. Nidhi. If anybody wants to join paid course, you can use this referral code to get additional 10% off. I've taken many plus classes, many special classes, so anytime you can join and revise your topic. So let's mark your NEET PG 2023 free 6-month subscription extension on the subscription of 1 year. So do enroll yourself right now by using the code that is Dr. Nidhi, because you are getting 6-month extension by free of a cost. The price hike is going to be very soon by up to 20%. So enroll yourself so that you will save this 20% and get additional 10% off by using the code that is Dr. Nidhi. So we are having two type of subscription, a plus subscription as well as iconic subscription. What all are the benefits? First, coming to this plus subscription. When you take this plus subscription, you are able to access both the live and recorded session. By chance, if you miss any session, you can see the recorded version. Good morning, Dr. Rakesh. You have an opportunity to learn from India's top educator for the medical examination. We always conduct this live tests and live quizzes. From that, you can analyze your preparation at any point of time. You have flexibility. You can study on the device of your choice. आपका phone हमेशा आपके साथ होता है. So you can go for the lecture anywhere. So we have a question bank which consists of a 25,000 plus question, high yield question, and clinical based question, and with explanation. So this is going to be very beneficial for all of you. Good morning, everybody. So now moving to the iconic subscription, what all are the benefit? You will be getting access of India's two best platform, that is Unacademy and the Prep Ladder. So you are going to get all the plus benefit, like I said, like live classes, recorded classes, question bank, live tests, live quizzes, and the PDF. Along with that, you get access for this Prep Ladder. And this you can access the clinical and integrated essential of Prep Ladder, video lecture from the Dream Team, Question Bank 3.0, rapid revision and snapshot, and you will also be provided with that treasure and dream notes. So if you are looking for the subscription that include both, so you can go for the iconic subscription. So now coming to the special class feature, our special class is also free of cost, but they are way more special than this YouTube session. How they are special? Because they are always and always live. Live interactive sessions are there, polls feature are there. From that, class is very engaging. Raise a hand feature is there. Now you can talk to your educator in the live session and clear your doubt in live classes only. If you follow any educator, you will get notification of their upcoming classes. After the lecture, you can download the PDF and revise it anytime, anywhere. So download your Unacademy learning app right now. So we are started with this Unacademy Lite for NEET PG, where you get access of all the test series like subject wise test, system wise test, full length mock test paper, previous year question paper, test series curated by top educator, and all the grand tests like NEET PG, INICT, and FMG will be also included in this Unacademy Lite. So this is the free test calendar for the upcoming week. So do remember this one. Take a screenshot of this one and do give all the tests, because from that test you are going to see how you are preparing for your upcoming examination. We are started with this UPSC batch, CMS revision batch, and previous year question batch. So next is the target. Next 2023 batch is also going to be started from today. Take a 6-month duration will be there. So if you are looking for the next 2023, you can join this batch, everybody. So we are having this NEET PG previous year question bank, where you get access of the 4-year paper of NEET PG, INICT, and FMG, and the dedicated solution session will be there for each questions. 180 plus question is now available for the free users. Auto daily practice paper is also started. After the every plus classes you get 5 to 10 MCQ that is handpicked by your educator, and that is related to topic you studied in that session, and that is going to enhance your conceptual understanding. So we are launched with this UPSC CMS batch, and its fee structure is somewhat like this. 1 month fee is 2,475, 2 month fee is 4,500 only. So moving further, we are started with this first prof batch also. 3 month prices 4,950, 6 month fee is 9,000. 12-month fee is 10,800 only. So this is the fee structure of each and every NEET PG subscription. This is the fee structure for the Plus subscription. This is the fee structure for the Iconic subscription. This is the fee structure for the Light subscription. And this is the fee structure for MBBS First Prof. So as per your requirement, you can enroll yourself and start your preparation right now. So moving to our topic, we will continue this excretory system. Today we are going to study about the proximal convoluted tubule. First, coming to the introduction part. This proximal convoluted tubule cells are characterized by two important things. First is this brushed border epithelium. Presence of this microvilli is going to have this brushed border epithelium of the PCT cell, and this is helping to enhance the surface area for the reabsorption. This PCT cell is also characterized by presence of this abundant mitochondria. This abundant mitochondria is responsible for active reabsorption that is occurring in our PCT. So do remember, the brushed border epithelium and the presence of abundant mitochondria is the characteristic feature we will see in the PCT cell. So next is also the very important point, that is PCT reabsorb. This PCT reabsorbs 70% of a major electrolyte like sodium, potassium, calcium, chloride. 70% of water is also reabsorbed. 100% of glucose is reabsorbed out here. 100% of amino acid is reabsorbed out here. 80 to 90% of a bicarbonate is reabsorbed out here. So these all points are very important. PCT reabsorb 70% of a major electrolyte like sodium, potassium, calcium, chloride. 70% of water is reabsorbed out here. 100% of glucose and the amino acid is reabsorbed out here. So do remember this one. This is important from the exam point of view. So moving further, see, this is the diagram. This is our proximal convoluted tubule, and this is responsible for absorption of all these. Our major electrolyte are reabsorbed out here, water is reabsorbed out here, glucose, amino acid, protein, vitamin, lactate, urea, uric acid, all are reabsorbed out here. So moving further, this is also the important diagram. This is our PCT cell. Okay, and this is the blood vessel and this is the lumen of the proximal tubule. So all the things that is reabsorbed from the lumen into the PCT cell is occurring via this sodium hydrogen exchanger. Okay, so see, chloride is reabsorbed with the help of this sodium hydrogen exchanger. Calcium is reabsorbed with the help of this sodium hydrogen exchanger. Amino acid is reabsorbed with the help of sodium hydrogen exchanger. Glucose is reabsorbed. Phosphate is reabsorbed. So all the reabsorption that is occurring in the PCT is with the help of the sodium hydrogen exchanger. Since it is an exchanger, it is a classical example of secondary active transport. So that's why energy is required, and that's why the presence of abundant mitochondria is there in our PCT cell. Is this clear with everybody? Do reply fast. Is this clear? Shall we move to the further? Okay, so moving further. Now coming to the water reabsorption in our PCT. The water reabsorption out here is 70% and that occur via this osmosis. So the water reabsorption occurring in our PCT is via the osmosis, yani it is occurring via the passive transport, and this water reabsorption is not any under hormonal control. So that's why it is also known as obligatory water reabsorption. Means irrespective of a body osmolarity, 70% of water will be reabsorbed in the PCT in all the situation. So that's why it is known as obligatory water reabsorption. Okay. So moving further, the glucose reabsorption, 100% of glucose is reabsorbed out here. Okay, and that occur via the sodium glucose co-transporter. This is a co-transporter, so it is a classical example of secondary active transport. So now coming to the clinical aspect, when we give this SGLT2 blockers, so this glucose will be not reabsorbed in our PCD, so it will be excreted out in our urine. So that's why it is used in the treatment of diabetes mellitus. Okay. So do remember SGLT2 is responsible for glucose reabsorption in the PCD and it is a classical example of secondary active transport. It also required ATP. Okay, so next is the diagram. This is important diagram. This is our PCD cell. This is the blood vessel end. And this is the lumen part. From the lumen, this glucose is taken inside the PCD cell via this SGLT2 blockers. Sorry, SGLT2. So what happened? This glucose is taken inside the blood via the passive transport via the GLUT2. So this is important. From the PCD to the blood, this glucose is transported via GLUT2. It is a classical example of a passive transport. And while this glucose is taken inside the PCD from the lumen via this SGLT2, so this is a classical example of secondary active transport. So moving further, this is the diagram. This is the S1 segment of PCD and this is the S2 and S3 segment of PCD. So 90% of glucose is reabsorbed from this S1 segment. So because this SGLT2 proteins are present out here, so 90% of glucose is reabsorbed from S1 segment. So our SGLT2 blockers will also act on S1 segment. Okay, so our all the glyphosate groups of drug like canagliflozin, dapagliflozin and empagliflozin all are going to cause SGLT2 blocking. And due to that, what happened? Glucose will not be reabsorbed in the PCD. Glucose will be present in our urine. So we all know glucose is a good culture media. So that's why the most common side effect when we give this SGLT2 blocker is the UTI. Since glucose is a good culture media, it is going to lead the UTI. Is this clear with everybody? Shall we proceed to the further? Okay, moving further. See, the transport max of a glucose is there. Why is it is the transport max of glucose is there? Because after a certain period of time, when we increase plasma glucose, the concentration rate of transport is going to increase. So, but after certain period of time, what happened? All the transporter will be involved. So, after that, when we increase the plasma glucose level, the rate of transport is not going to increase. So, the saturation is reached. Glucose reabsorption is going to stop after that. Okay? So, this point is known as a transport max of glucose or the Vmax. Okay? And the plasma glucose concentration at which this transport max is achieved is known as renal threshold for the glucose. Okay, so this is the data which you have to remember. The transport max of glucose is 375 milligram per mm of Hg, and the renal threshold of glucose is 200 milligram per deciliter. What do you mean by this renal threshold of glucose? Means after 200 milligram per deciliter, the rate of transport is not going to increase, so the glucose will start to appear in the urine, and that is going to lead this renal glycosuria. Is this clear? So these two data are important. Transport max of glucose is 375 milligram per mm of Hg. Renal threshold of glucose is 200 milligram per deciliter. Is this clear? Moving further. Now coming to the tubular fluid upon a plasma ratio. This ratio is going to assess the reabsorption power of the PCT. How it is going to show the reabsorption power of PCT? Suppose the tubular fluid upon a plasma ratio is equal to 1. Means substance is reabsorbed same as the water. So water reabsorption in PCT is how much? Anybody? How much water is reabsorbed in the PCT? Anyone? The water is reabsorbed 70% in the PCT, remember? So all those substance which is 70% reabsorbed in the PCT is having this tubular fluid upon plasma ratio equal to 1. Means sodium, potassium, chloride, calcium, all having 70% reabsorption in the PCT. So all having the tubular fluid upon plasma ratio equal to 1. Means same amount of water is reabsorbed, same amount of electrolyte is reabsorbed. So fluid will be isotonic with the water. The tonicity remains same. Is this clear, everybody? Okay, coming to the next situation, that is the tubular fluid upon a plasma ratio less than 1. Means substance is reabsorbed more than water. Water is reabsorbed 70%. The substance that is reabsorbed more than this one will have tubular fluid upon plasma ratio less than 1. So glucose is reabsorbed 100%. Amino acid is reabsorbed 100%. Bicarbonate is reabsorbed 80 to 90%. So that's why we can say these all substance will have a tubular fluid upon plasma ratio less than 1. Is this clear? Now coming to the next situation, that is the tubular fluid upon plasma ratio more than 1. Means substance is reabsorbed more than water. How much water is reabsorbed? 70% water is reabsorbed. Okay. So those substance that is reabsorbed less than water is going to have a tubular fluid upon a plasma ratio more than 1. So our inulin, which is not reabsorbed, neither secreted and free. So inulin के लिए criteria क्या था? For measuring GFR, it should be freely filtered, no reabsorption should occur, no secretion should occur, and it should be non-toxic in nature. So this inulin is not reabsorbed. So we can say it is reabsorbed less than water. So it is having this tubular fluid upon plasma ratio greater than 1. Creatinine is also reabsorbed less, or you can say no reabsorption occur. So it is also having tubular fluid upon plasma ratio more than 1. Our urea, 50% of urea is reabsorbed in the PCT. So this urea is also plasma ratio more than 1. So see, this is the diagram, this is the curve. On x-axis we take this percentage total proximal tubular length, and on y-axis we take this ratio tubular fluid upon the plasma ratio concentration. So first is the tubular fluid upon plasma ratio equal to 1, Means substance is reabsorbed the same as a water. So means substance is reabsorbed 70%. So our sodium, our chloride, our potassium, our calcium, all will be having tubular fluid upon plasma ratio equal to 1. And now the curves that is coming down is having tubular fluid upon a plasma ratio less than 1. Means substance is reabsorbed more than 70%. A bicarbonate is reabsorbed more than 70%. Glucose is reabsorbed more than 70%. Amino acid is reabsorbed from more than 70%. So it is having tubular fluid upon plasma ratio less than 1. So all the curve that is coming up is having tubular fluid upon a plasma ratio more than 1. Means substance is reabsorbed less than 70%, lesser than water. So in this we have urea, creatinine, inulin. Is this clear with everybody? So this is all about the tubular fluid upon a plasma ratio. Everyone, is this clear? So moving further, now coming to the loop of Inlay. This loop of Inlay consists of a two-part. Descending limb of loop of Inlay and the ascending limb of loop of Inlay. First, coming to the introduction part, what is the function of this loop of Inlay? It is responsible for concentration and dilution of urine. This concentration and dilution of urine are act by loop of Inlay acting along with the Vasa Rector to form the countercurrent system, and this countercurrent system is going to responsible for concentration and dilution of urine. The loop of Inlay consists of a two important parts. That is the descending limb of loop of Inlay and the ascending limb of loop of Inlay. This descending limb of loop of Inlay start from cortex, goes to the medulla. Ascending limb of loop of Inlay start from medulla, it goes to cortex. It basically consists of two parts: thick ascending limb of loop of Inlay and thin segment of ascending limb of loop of Inlay. So now coming, what do you mean by this counter current system? When two systems are close to each other, but the direction of a fluid movement is opposite, then they form the counter current system. Okay, let me draw a diagram for all of you. This is our descending limb of loop of Inlay. This is our ascending limb of loop of Inlay. Okay, now drawing the Vasa Rector. This is our ascending limb. Okay, 1 second. This is our descending limb of Vasa Rector and this is our ascending limb of Vasa Rector. So this is our Vasa Rector. This is our loop of Inlay. This is our descending limb of loop of Inlay. This is the ascending limb of loop of Inlay. This is descending limb of Vasa Rector. This is ascending limb of Vasa Rector. So we are seeing this descending limb of loop of Inlay and the ascending limb of Vasa Rector are close to each other. Okay, and the direction of fluid movement in these both tube is opposite. So they form the counter current system. Okay, so out here also the Vasa Rector will be present. So out here the descending limb of Vasa Rector is there. So this descending limb of Vasa Rector and ascending limb of loop of Inlay is having the counter current system. Okay, so is this clear? What do you mean by this counter current system? Two segments are close to each other, but the direction of a fluid movement is opposite in this both tube. So then they form this counter current system. This counter current system, beside in loop of Inlay, it is also present in our limbs. Testis in the form of papilliform plexus and intestine in the form of villous circulation. So this is very, very important from the exam point of view. The counter current system beside in loop of Inlay is also present in limbs, testis in the form of papilliform plexus, in the villous circulation of intestine we have this counter current system. So see, moving further, this is the diagram. This is our Bowman's capsule. The glomerular filtrate will come on this Bowman's capsule. It will reach to this proximal convoluted tubule. Then it goes to this loop of Henle. So now coming how this counter current system work. Fluid that is reaching to the descending limb of loop of Henle is isotonic because the fluid is coming from the PCT, and in PCT we already discussed the water reabsorption is 70%, electrolyte reabsorption is also 70%. So the PCT will have isotonic fluid. So the fluid that is reaching to descending limb of loop of Henle is isotonic, and its osmolarity is about 300 milliosmol. Okay, so next coming to the descending, first coming to this descending limb of loop of Henle. This descending limb of loop of Henle is only and only permeable to water. It is not permeable to electrolyte. And this water permeability of this descending limb of loop of Henle is due to presence of this aquaporin 1. Okay, so due to water reabsorption, what happened? Electrolyte will accumulate inside the tube. So due to accumulation of electrolyte inside the fluid, inside the tubular fluid, the osmolarity is going to increase. So basically osmolarity multiplies. From 300 it goes to 600, from 600 it goes to 900, and from 900 it goes to 1200 milliosmol. Okay, so that's why the descending limb of loop of Henle is known as counter current multipliers, or you can say it is also known as concentrating segment. Because osmolarity is multiplying, it is known as counter current multiplier, and concentration is increasing, so it is also known as concentrating segment of our nephron. Is this clear with everybody? About the descending limb of loop of Henle, is this clear with everyone? Do reply fast. Those who don't want to attend the lectures, please don't disturb others. Is this clear with everyone? The descending limb of loop of Henle. Okay, same thing is written out here. At the tip of segment, at the tip of loop of Henle, the osmolarity is a maximum. It is a 1200 milliosmol. And the descending limb of loop of Henle is known as a concentrating segment or counter current multiplier, because osmolarity multiplies from 300 to 1200 milliosmol. So see, this is the diagram. This is the fluid reaching in a descending limb of loop of Henle. That is coming from PCT, and it is isotonic to water, and its osmolarity is 300 milliosmol. And this descending limb of loop of Henle is permeable to water, and this permeability is due to presence of aquaporin 1. So the osmolarity is going to increase because our solute will accumulate, our electrolyte is going to accumulate inside the fluid. So it is going to multiply from 300 to 600, and at the base it is the maximum, that is 1200 milliosmol. Same diagram here. This is the proximal convoluted tubule, and this is our descending limb of loop of Henle. Both are having this aquaporin 1 for water reabsorption. Okay, so moving further, now coming to the ascending limb of loop of Henle. This ascending limb of loop of Henle is permeable to solutes. It is impermeable to water. So the solute permeability in ascending limb of loop of Henle is basically due to presence of the sodium potassium twice chloride co-transporter. That is responsible for reabsorption of sodium, potassium and twice chloride. So since it is a co-transporter, it is a classical example of secondary active transport. Okay, and this channel is also known as the Barton's channels. Why it is known as Barton's channel? Because sodium reabsorption. Because the mutation of this channel, this sodium potassium twice chloride channel, leads to Barton's syndrome. That's why this is also known as the Barton's channel. So what happened out here? The sodium reabsorption is there. So water is going to accumulate in the ascending limb of loop of Henle. So osmolarity is going to decrease. So it is also known as a diluting segment of a kidney. Is this clear? Now coming to the sodium potassium twice chloride co-transporter mutation leads to this Barton syndrome. That's why it is also known as Barton's channel. And this channel is blocked by loop diuretics. So you will study this in medicine part. So do remember. Coming to the further. So see, this is the diagram. This is the part of ascending limb of loop of Henle. This consists of a sodium potassium twice chloride co-transporter, due to which what happened? From the lumen, this is taken inside the ascending limb cells. Okay, and this is blocked by loop diuretics or furosemide. Is this clear with everybody? So moving further, this is the summary. In the PCT, the nature of fluid was isotonic. In descending limb of loop of Henle, the nature of fluid was hypertonic because it is permeable to water. So our solute is accumulating, so the fluid become hypertonic. Ascending limb of loop of Henle is permeable to solute, so water is accumulating, so the nature of fluid out there was hypotonic. So moving further, now coming to the Vasa Vector. What does this Vasa Vector do? And what is this Vasa Vector? First and foremost important point, what is this Vasa Vector? It is a portion of our peritubular capillary bed. So along with the loop of Inlay, it formed the countercurrent system we already discussed. So what happened? The water that is removed from descending limb of loop of Inlay is taken by the ascending limb of Vasa Recta. So let me take you to that diagram again. So we all know descending limb of loop of Inlay is permeable to water, and this water is taken by this ascending limb of Vasa Recta. Okay, this ascending limb of loop of Inlay is permeable to solute, and this is taken by the descending limb of Vasa Recta. So what happened? This solute and water loss is prevented. It is uptaken by this Vasa Recta. So it is going to prevent the solute and water washout. So it is also going to maintain the osmolarity gradient in our medulla. This osmolarity gradient is there, and that is maintained by this Vasa Recta. So there is a two role of this Vasa Recta. It maintains the osmolarity gradient that is established by the loop of Inlay, and it prevents the washout of solute and the water. So these are the two important roles played by our Vasa Recta. Along with the loop of Inlay, this Vasa Recta form countercurrent system, and they are responsible for concentration and dilution of urine. Is this clear with everybody? Do reply fast. Is this clear? If anybody has any doubt till now, you can ask in the session only. Do reply fast. Is this clear with everyone? Shall we move to the further? Okay, moving further. See, this is the diagram. This is our nephron. This is the Vasa Recta. This is the descending limb of loop of Inlay, which is permeable to water, and this water is uptaken by ascending limb of Vasa Recta. This ascending limb of loop of Inlay is permeable to solute, and this solute is taken by the descending limb of Vasa Recta. So this is the diagram. So moving further to the last one, that is the classification of nephron. So this nephron is classified into two categories on the basis of the size of a loop of Inlay. It can be either cortical nephron or the juxtamedullary nephron. The cortical nephron is having this loop of Inlay, which is having the shorter loop of Inlay. And this cortical nephron is the numerous one. 85% of our nephron are the cortical nephron, which is having shorter loop of Henle. The JG nephrons is having long loop of Henle and it is only 15%. So this is having only the long loop of Henle. So it is also only having the connection with the Vasa Recta. So it is only having the counter current system. So it is only nephron which is responsible for concentration and dilution of urine. So this is the difference between these two nephrons. See, this is the diagram. This is the cortical nephron. And this is our juxtamedullary nephron. This cortical nephron are the maximum one. 85% of our nephron is cortical nephron, while only 15% of our nephron is juxtamedullary nephron. This is having loop of Henle shorter, and this juxtamedullary nephron is having longer loop of Henle. Okay, so this is the basic difference, and out here there is a Vasa Recta, and that Vasa Recta is responsible for concentration and dilution of urine. Moving further, so coming to the question part. First question of today's session. All are true except PCT is permeable to water. Descending limb of loop of Henle is permeable to water. Thick ascending limb is permeable to water. Distal tubule is permeable to water. So everybody answer this question. All are true except. Do reply fast, everyone. All are true except. Very good, Dr. Soumya. Answer is C. Thick ascending limb of loop of Henle is permeable to solute, not to the water. PCT is permeable to water. 70% of water is reabsorbed in the PCT. Yeah, distal tubule is also permeable to water. The ADH act on the distal tubule and collecting duct cause water reabsorption. Okay, so answer is only and only C. Coming to the next one. Mechanism by which water is reabsorbed in the PCT is active transport to passive transport, facilitated diffusion, or the osmosis. The mechanism by which water is reabsorbed from the PCT is the mechanism by which water is reabsorbed from the PCT is the osmosis. Very true. It is via the osmosis. We already discussed this one in today's session. Coming to the next one, the main site of a bicarbonate reabsorption is the PCT, DCT, cortical collecting duct, or the medullary collecting duct. Do reply fast, everybody. The main site of a bicarbonate reabsorption is our proximal convoluted tubule, 80 to 90%. Some books says 100% of bicarbonate is reabsorbed in the PCT. So answer is only and only A. Coming to the next one. Bicarbonate is absorbed directly in PCT, indirectly in PCT, directly in DCT, indirectly in DCT. Everybody answer this question fast. Bicarbonate is absorbed Yeah, way through Dr. Soumya, it is indirectly absorbed in the PCT because all the reabsorption in the PCT is via this sodium hydrogen exchanger. So we can say it is in reabsorbed indirectly in PCT, not directly in PCT. Is this clear with everybody? So answer is C. Coming to the next one, the principal site of absorption of sodium is PCT, DCT, loop of Inlay, or the collecting duct. The principal site of absorption of sodium is the principal site of absorption of sodium is PCT. 70% of sodium is reabsorbed out there. Way true. Answer is A. Coming to the next one, maximum phosphate is reabsorbed in PCT, DCT, loop of Inlay, or the collecting duct. No, it's not DCT or loop of Henle. Maximum phosphate, 70% of phosphate is also reabsorbed in the PCT. Coming to the next one, ascending limb of loop of Henle has a which transporter? Sodium chloride co-transporter, sodium potassium twice chloride co-transporter, epithelial sodium channel, or sodium amino acid co-transporter. So everybody answer this question fast. Ascending limb of loop of Henle has which transporter? Ascending limb of loop of Henle has the which transporter? Epithelial, sodium potassium twice chloride co-transporter is present in our ascending limb of loop of Henle. Coming to the next, not reabsorbed in the PCD, sodium phosphate, bicarbonate, or hydrogen ion. Not reabsorbed in the PCD. Not absorbed in the PCD. Yeah, way to Dr. Soumya, it's hydrogen ion. Hydrogen ion is excreted out via the sodium hydrogen exchanger. Sodium ion is taken inside the PCD cell. Hydrogen ion is excreted from the PCD cell. So this is not reabsorbed. It is excreted out. So answer is D. Very true. Coming to the next one. Glucose is transported in renal tubular cell by potassium symport, so potassium antiport, sodium antiport, sodium co-transport. Glucose is transported in renal tubular cell by do reply fast, everybody. Yeah, very true. It is by the sodium co-transport that occur via SGLT2, sodium glucose co-transporter 2. That is answer is D. Very true. Coming to the next one. True about ascending limb of loop of Henle. Receive hypertonic saline, maximum absorption of fluid occur, respond to ADH or reabsorb hydrogen ion. True about ascending limb of loop of Henle. No, loop of Henle doesn't respond to our hormonal. Okay, so ADH is not going to act at the level of ascending limb of loop of phase. Ascending limb of loop of Inlay is receiving the fluid that is coming from descending limb of loop of Inlay, and descending limb of loop of Inlay is permeable to water, so the electrolyte accumulate out there. So the fluid that is coming from from descending limb of loop of Inlay will be hypertonic. So we can say ascending limb of loop of Inlay receive the hypertonic saline. Is this clear? Everybody. Sodium, potassium, twice chloride transporter was there. So these three were reabsorbed and not hydrogen ion. Coming to the next one. True about renal secretion, maximum reabsorption in distal tubule. Urea is 100% reabsorbed in the proximal tubule. Hydrogen ion is reabsorbed in the proximal tubule. Glucose is reabsorbed in the proximal tubule. True about the renal secretion. Yeah, wait, glucose is 100% reabsorbed in the PCT. Okay, so answer is a D. Very true. Coming to the next one. In the proximal tubule, bicarbonate is reabsorbed with the help of sodium chloride co-transporter, sodium potassium twice chloride co-transporter, sodium hydrogen exchanger, or sodium potassium exchanger. So everybody answer this question fast. In the proximal tubule, the bicarbonate is reabsorbed with the help of yeah, very true. Very true, Dr. Soumya. We already discussed in our session all the reabsorption that is occurring at the level of PCT is with the help of a sodium hydrogen exchanger. So we can say all the reabsorption is occurring indirectly in the PCT, not directly because it is involving this exchanger. So answer is C. Is this clear with everybody? Answer is not A, not B, not D. This is only and only C. Everyone do reply fast. Is this clear? Okay, moving to the next one. In a healthy individual on a normal diet, which of the following ion is completely reabsorbed in the tubules? Sodium, potassium chloride, or bicarbonate? In a healthy individual on a normal diet, which of the following ion is completely reabsorbed in the tubules? No, sodium is almost sodium, potassium chloride, all are 70% reabsorbed, while the bicarbonate is 80 to 90% reabsorbed. So we can say, and some book also says the bicarbonate is 100% reabsorbed out here. So answer is not A, it is D. Is this clear? Everyone, is this clear? Okay, moving to the next one. least reabsorbed out of the following: glucose, urea, sodium, or bicarbonate. Least reabsorbed out of the following is glucose, urea, sodium, or bicarbonate. Yeah, way true. Urea is only 50% reabsorbed in our PCT. So it is the least reabsorbed out of the following, because glucose is 100% reabsorbed, sodium is 70% reabsorbed, bicarbonate is 80 to 90%, or some books says 100% reabsorbed. Okay, coming to the next one. Substance that is completely reabsorbed from the kidney. The substance that is completely reabsorbed from the kidney. Sodium, potassium, urea, or glucose. This is an easy one, I guess. Yeah, glucose is 100% reabsorbed. Coming to the next one. True about the calcium reabsorption. True about the calcium reabsorption in a kidney. Option A, most of the calcium reabsorption occur in the DCD. Major regulating factor is the parathormone. Parathormone decreases the calcium reabsorption, increases phosphate, increase plasma phosphate, decrease calcium reabsorption. True about the calcium reabsorption in the kidney. True about the calcium reabsorption in a kidney. Yeah, very true. Answer is B. The major regulating hormone is the parathormone. See, the most of the calcium is reabsorbed in PCD, not in the DCD. 70% of the calcium is reabsorbed out here. So this is wrong. Parathormone decreases calcium reabsorption. No, it increases the calcium reabsorption and decreases the plasma phosphate. So that's why it is known as a phosphatidylcholine. Because it is a phosphate excreting hormone. Our parathormone is a phosphate excreting hormone, not a phosphate increase. So that's why it is known as a phosphatidylcholine. So answer is only and only B. Coming to the next one. Normal renal threshold of glucose is at plasma glucose level 100 milligram per deciliter, 200 milligram per deciliter, 300 milligram per deciliter, or 400 milligram per deciliter. Renal threshold for glucose is at a plasma glucose level. The normal renal threshold of glucose is 200 milligram per deciliter. The transport max of glucose is 375 milligram per deciliter. But the renal plasma glucose level after which renal glycosuria will be seen, or you can say renal threshold of glucose, is 200 milligram per deciliter. Is this clear with everybody? So answer is not C, it is B. Coming to the next one, which of the following is a diluting segment of a kidney? PCD, collecting that ascending limb of loop of Inlay or the descending limb of loop of Inlay. Which of the following is a diluting segment of kidney? Yeah, way to ascending limb of loop of Inlay is the diluting segment, while descending limb of loop of Inlay is the concentrating segment. Coming to the next one. The role of Vasa Recta is regulating tubulo-glomerular feedback mechanism, regulating GFR, concentration of urine, or supplying the suprarenal medulla. The role of Vasa Recta is the role of Vasa Recta is it is responsible for concentration and dilution of urine. Answer is a C. No, not answer is not A. Tubulo-glomerular feedback, it is done by the macula densa. When GFR increases, the macula densa is activated. It is going to release the adenosine. Adenosine is going to cause contraction of our afferent arteriole. And that's how GFR decreases. This is tubulo-glomerular feedback. Is this clear, Dr. Farhana? Answer is C. The Vasa recta is responsible for concentration and dilution of urine. Which of the following is true regarding urea? Transported through aquaporine, reabsorbed in the PCT, no role in concentration of urine. Reabsorption is independent of ADH. Which of the following is true regarding urea? It is reabsorbed in PCT. 50% is reabsorbed in the PCT. No role in concentration of urine. No, it is this urea and sodium is responsible for hyperosmolarity of our renal medulla. These two are responsible for maintaining the hyperosmolarity of renal medulla, and that's why the Vasa Rector along with the loop of Inlay is working, and they are helping in concentration and dilution of urine. So answer is the B only. Is this clear with everybody? Coming to the next, countercurrent mechanism in the kidney is responsible for absorption of glucose, maintenance of a blood flow, osmotic gradient in medulla, secretion of uric acid. Countercurrent mechanism in the kidney is responsible for way two, it is responsible for maintaining the osmotic gradient in the medulla. Countercurrent blood flow is seen in all except kidney, eye, testis, small intestine. Everybody answer this question. Countercurrent blood flow is seen in all except. Yeah, very true. It is not seen in eye. It is seen in our kidney, loop of Inlay along with the Vasa Rector. In Papniform plexus also, in villus circulation also, we have this countercurrent blood flow. It is not present in our eye. Very true. Coming to the next question. Which of the following is not a component of countercurrent multiplier? Ascending limb of loop of Inlay, collecting duct, Vasa Recta, or the descending limb of loop of Inlay. Which of the following is not a component of countercurrent system? I guess this is the easy one. Yeah, collecting duct is not a part of our countercurrent system. Coming to the next one, high sodium content of the filtrate in the renal medulla is because at the loop of Inlay there is a countercurrent mechanism. Collecting duct to Vasa Recta, descending limb of loop of Inlay. High sodium content of the filtrate in a renal medulla is because. Yeah, at the loop of Inlay there is a countercurrent system. Okay, sorry. This will be the answer. High sodium content of filtrate in renal medulla is because the descending limb of loop of Inlay is permeable to water. So answer is D. Is this clear with everybody? Coming to the next one. Hyperosmolarity of a renal medulla is due to potassium, sodium, glucose, or chloride. Hyperosmolarity of a renal medulla is because of. Hyperosmolarity of renal medulla is due to presence of the sodium and the urea. Very true. Coming to the next one. Countercurrent mechanism, all are true except occur due to opposite flow in Vasa Recta and loop of Inlay, seen in medullary nephron, help in creating osmolarity gradient. Urea has no role. Countercurrent mechanism, all are true except everybody answer this fast. Yeah, way to Dr. Vashni. Answer is D. Urea and sodium is responsible for maintaining the higher osmolarity at the renal medulla. Okay, countercurrent system is, what is this countercurrent system? If the two tubes are close together and the blood flow in this two tube or the flow in this both tube are opposite, then it is forming this countercurrent system. So this is the complete definition of our countercurrent system. It is present in cortical nephron because cortical nephron has a long loop of Henle and they are responsible for creating osmolarity gradient. Very true. Coming to the next, maximum osmotic gradient is found in outer medulla, inner medulla, outer cortex, or the inner cortex. So this is the last question of today's session. To answer everybody fast. Maximum osmotic gradient is found in yeah, it is present in our inner medulla. Is this clear with everybody? Very true. The osmolarity of inner medulla is 1200 milliosmol. Okay, so answer is B. So this was the last question of today's session. If anybody has any query regarding today's session, you can ask. So hope you all like this session. If you like this session, do share. That is important. Regular मेहनत करते रहिए. You will definitely able to achieve your target. You will definitely crack your exam with good rank. Do more and more MCU. That is the only key to success. So do more and more MCU. That is going to help you to crack your exam with good rank. Thank you so much for joining. See you all in the next session. This is the code Dr. Nidhi. If anybody wants to join paid course, you can use this referral code to get additional 10% off. Price hike is going to be in very soon, 2 to 3 days after. The price hike is going to be very soon by 20%. So you can save this 20% by enrolling yourself right now. Thank you so much for joining. See you all in the next session. Bye bye everyone. Most welcome everybody.